therapy students. This is a little video to kind of just review what you might see on exam 2. It's all about like infection, transmission precautions, and how that relates to IV therapy, because IV therapy is a necessary treatment for most people that come into our healthcare system, but it also is a venue, I should say, for infection because it goes directly into the bloodstream. Okay, so in this video, we're going to talk about first transmission-based precautions in healthcare settings. So contact precautions are used if you think you're going to be contaminated from body fluids, okay? So you're going to wear personal protective equipment. So that's your gown and gloves for contact precautions. They should be in a private room as well. If you do have to cohort people, you cohort people with like disease. So hopefully you won't have C. diff with C. diff, but that's an example, or like MRSA with MRSA. Hopefully you're working in a place where you can't have a private room. Okay, the next type of transmission-based precaution is droplet precautions, and this is used for diseases transmitted by large droplets, and it's within a distance of 3 to 6 feet. The only requirement is you have to wear a mask. If the patient needs to go anywhere, they have to wear a mask, and they need to stay 3 feet from other people. And these kind of conditions that go into droplet precautions are mostly like respiratory conditions like pertussis, pneumonia. Those are some examples, okay? And then with TB, don't get confused. TB it's a respiratory disease, and the hallmark, like what you would see in a patient, is night sweats, cough, and an afternoon fever. If you hear that, you should be thinking, this patient has TB, I need to get them in a negative pressure room by themselves. If they need to leave their room, they wear a surgical mask because TB is airborne. So it's airborne. We use airborne precautions for diseases transmitted by tiny droplets. So these are even smaller than the droplets in droplet precautions, okay? So they need to be in a negative pressure room. Sometimes you'll hear that referred to as negative pressure exchanges or HEPA filters in the room, okay? So what you're going to need to wear is an N95 mask in that room, and they need to be in a private room, obviously. So if you detect somebody has TB or like shingles, herpes zoster, get them in a private room, okay? N95 mask, that of course is the respirator mask for healthcare professionals that are taking care of people on airborne precautions. Surgical mask is worn by all patients leaving the room to prevent droplet spread, whether they're on airborne or droplet, they wear a surgical mask. VRE is vanc resisted enterococcus, I think it's the term in the end. But anyways, that's contact precautions. Meningitis is droplet. And what you'll typically see as a question is, you know, there's a waiting room and you've got a child that comes in with a high fever, headache, and they have developed a rash. Get them to a private room. Get them away from all the other children in the room, because that child may have meningitis. MRSA, I'm sure you've heard of that and run into it in clinical. That's contact. C. difficile is contact as well. What you need to remember about C. difficile is that after you take care of a patient, you need to use soap and water to wash your hands. And when you wash your hands with soap and water, remember, you rinse your hands first. The hands have to be wet. And you're going to use soap and then friction for 15 seconds. If your hands are soiled, use soap and water for 2 minutes, okay? Alcohol gel can be used for most other conditions in between patients. The difference with alcohol gel is that you want to put it on dry hands, okay? And when you're done with soap and water washing, you need to dry your hands, you know, pat them dry with the towel. All right, pertussis is droplet. We have seen an uptick in pertussis, which is whooping cough, because less people are getting immunizations these days. So you may run into that. TB It is an airborne infection and it affects the lungs. And varicella zoster, this is the virus that causes chickenpox. And in older adults and younger adults can get this too. They can get shingles. So that is a rash. It's described as burning pain, and it's only on one side of the body. It doesn't cross over. It stays on one side. It's in a dermatome. So it's like in a nerve root, okay? So if you have a scenario where somebody's complaining of a burning rash and it's on one side of their body, get them in a private room. They need to be in an airborne negative pressure room. So the diseases that fall under airborne precautions, remember MTV for measles, tuberculosis, and varicella zoster. Okay, so that's transmission-based precautions. Now we're going to go to central lines. We talked about central lines in class. So the advantage of a central line is that it's immediate access, okay? It reduces patients' need for venipunctures because you can draw blood off of it. And there's a decreased risk of exservation, which means decreased risk of dangerous drugs leaking out into the skin. Central lines are put in through the subclavian or internal jugular, just to give you an example. And the tip of where the line ends is always going to be in the SVC, right above the right atrium, okay? So you can give large amount of fluids with central lines as well, okay? And then disadvantages of central lines, okay, there's going to be an increased risk of systemic infection because number one, it's an invasive procedure. It has to be strict sterile technique. There's a risk for bleeding. Like I think I mentioned in one of my other lectures when I worked in oncology, we had somebody with leukemia whose platelets were really low and they put her in a central line and she ended up dying. It was really tragic. She started bleeding and they couldn't stop it. And that's just extreme. Not, you're going to check your platelets before somebody gets a central line. You're going to check your patient's platelets. A guiding catheter can puncture like the lung. So that's why we always listen to lung sounds after somebody has a central line placed. And we always get a chest x-ray. Number one, to check the placement of the line. But number two, to make sure there's no pneumothorax. Okay. Now, a PICC line is a type of central line, which is inserted into a vein into the arm. And this can be done by a nurse and who has special training, not just any nurse. But anyways, a PICC line is good for patients that are going to go home with long-term antibiotics. We just finished talking about osteomyelitis. Remember how I said, like, this is something you definitely don't want your patient to have because they're going to go home with weeks and weeks of antibiotics. So they'll probably go home with a PICC line. What type of patient? A patient that needs vascular access up to 6 months would get a PICC line if they're going home. And a lot of people in if you go to the hospital that used to be called Vibra, a lot of those patients have PICC lines for the same reason because they need long-term antibiotics. Do not take a blood pressure in somebody with a PICC line in that arm, okay? We need an x-ray to verify location with all central lines, all central placements, okay? So the tip should be in the SVC right above the right atrium. Now, another type of central line is called an infusion port. So like a portacath, there's other names for them too, but that's the one I'm most familiar with. And it's a port used for long-term infusion care, like repetitive treatments, like for somebody that has an autoimmune disease and is getting, chemotherapy, or somebody with cancer that's getting chemotherapy. That's what it's mostly used for. And the infusion port, so it's placed under the skin. Let me see if I can pop up this picture. It's placed under the skin. Okay, that's the port. And this is where the nurse would access. And nurses have to be specially trained to be able to access this. And they use a non-coring needle so it doesn't pop a hole in this. It's kind of like a rubberized access point right here. Okay, so that is called a Huber needle, and it is non-coring, meaning the hole doesn't punch through the vascular access port. All right, so here's a picture of it. This is a non-coring needle. You see how if you push that down, it's not going to make a hole in the access point. Okay. Some of the possible causes of catheter occlusion. This could be with any central line. It could be clamped, kinked. The tip could be against the wall of the vessel. Patients can get thrombus, and there may be buildup in the lumen. Okay, what are some of the causes for an embolism? Catheter breaking. So anytime you remove an IV catheter, always check the tip to make sure it's intact, because if a little piece dislodges, it could become a thrombus, and cause an embolism. And air embolisms can happen with central lines too. Uh, and that's why you have to be specialty trained to pull a central line. Don't ever pull a central line unless you've been trained to do so. Okay, likely causes of infection. I mentioned that IV therapy is one of the main causes of healthcare associated infections. So it could be introducing, microbes during insertion or during use. Okay, so you have to use sterile technique when you're giving IV medications, when you're placing an IV, and certainly if a provider is doing a central line. Everybody in the room has to wear a mask, gloves, gown, and head coverings. Okay, it's serious, serious. Okay, um, what does CVAD mean? Central venous access device, and it can be done three different ways. We already talked about them. Centrally inserted catheters, so that could be like a central line that has 3 or 4 points that is non-tunneled, or a tunneled catheter. Okay, which means that skin has grown. It's inserted under the skin, and then it's inserted into the central line. Okay, peripherally inserted catheters and implanted ports we talked about. Really good for administering drugs or blood products and parenteral nutrition. Now, the central venous access devices have 3 or 4 lumens in them, right? So that means you can give meds that don't necessarily go together at the same time, because they don't mix in the blood because of the different lumens. Okay. And it can also be used for hemodynamic monitoring, which um, I'm not going to teach you this semester, and venous blood sampling I talked about. And extravasation injury, so that's leakage of medicine into the body. And if it's like chemotherapy, that can be very dangerous because it's toxic to the skin. It could slough off the skin. And some of the vasopressors also do this. That's why, like when I worked in ICU, this was a long time ago, they don't necessarily have this rule anymore. We weren't allowed to give dopamine through a peripheral line. We had to give all vesicants through a central line. Okay. So that's one of the reasons we put central lines in for people that are getting dangerous drugs. Okay. Now they can go into a couple different areas. The neck, they would use the jugular vein, the chest subclavian, which means under the clavicle. And then the groin is another one, but this would be like the totally last option, because the groin is very close to the peri area, which is a dirty area, right? So you would only insert, or I should say the provider would only insert a groin central line if it was absolutely the last ditch effort. Okay, they couldn't get it in anywhere else. So CVCs can have up to 4 lumens. If you get asked to grab a kit, always grab the one with the most lumens, because that means you can give the most drugs. And you'll understand if you ever work in ICU, sometimes you're giving a lot of drugs, and so you need those 4 lumens. Okay. PIC can be done at the bedside, and there's fewer insertion related problems. Okay, like causing a pneumothorax, etc. Phlebitis, I think you know by now, that's local inflammation of the walls of the vein, and the area is going to be warm to touch. Chemotherapy, here are all the drugs that we can give, or all the things we can do with the central line, okay? We can do dialysis for you, infusion of lots of medications. We talked about a lot of this. Now, don't memorize this. I'm just giving you some information. What manifestations would suggest an occluded catheter? Okay, if your pump keeps going off, or you can't aspirate blood from it anymore, that could be a sign. Now, typically, one thing you need to know about central lines, you always use a 10 ml syringe when you're, aspirating blood, flushing the line. 10 ml syringe. You may only use 5 mLs of saline to flush the line, but you're using it in a 10 ml syringe. Very important. It has to do with PSI. It's a physics thing, but just trust me, you need to use a 10 ml syringe. Okay, air embolism, if you're putting in a line or you're pulling one out and your patient has chest pain, respiratory distress, they have like shock-like vital signs, they're tachycardic and hypotensive, they could have occurred an air embolism. Get them on their left side in Trendelenburg. Now, because this will make the air embolism bubble go up into their right atrium, and the provider can take a syringe and try to extract it, okay? Other causes of embolism include breakdown of the catheter. That's why we always check it when we pull it out. We want to make sure it's intact. If there was a thrombus on the line and it gets dislodged, an entry of air, so air embolism. Okay. Nursing interventions. I kind of talked about this. Place the patient on the left side, head down, notify physician, clamp the catheter. And that's another thing too. When you have the central line, there's going to be 3 or 4 lines coming out of the neck. Make sure they're all clamped if you're not using them. If it's that, if you can ask if you can clamp them. Clinical manifestations of a systemic infection: fever, chills, malaise, hypotension, temperature. Those are all like systemic signs. Tachypnea, tachycardia. Local signs would be like redness, swelling, pus, drainage, warmth, edema. Okay. Your nursing interventions for a local infection is culture. If you're in there changing the central line and you see pus coming out of it, get a culture. Okay. Don't wait until you're done because you're already gowned and gloved, right? Have somebody bring you a culture kit. What are the nursing interventions for a systemic IV related infection? Oh, you don't want this to happen. Blood cultures, you'll have to start them on antibiotic therapy. You're going to get dinged by the Joint Commission, so it's not a good thing. You may have to remove the central line, and of course, you're going to give antipyretics to make them more comfortable. So, what is included in an assessment of a catheter insertion after you do it? You're going to always assess the site for redness, edema, warmth, drainness, signs of infection, signs of local infection. Most places now are doing a clear dressing over the central line with no like gauze on it so that you can see it directly. It allows you to keep the dressing on a little bit longer than if you had a gauze on it, which is good because the more times you do the dressing change, if somebody's breaking surgical protocol, asepsis protocol, that puts the patient more at risk for infection. Now, let's talk about IV therapy infection control. So we'll go through some of the terms that you probably already know from fundamentals, but we'll just review them. So surgical asepsis refers to sterile technique, whereas medical asepsis refers to clean technique, which inhibits the growth and transmission of microorganisms. And hand washing is like the priority intervention you are going to do in medical sepsis. Oh, and there it is, hand washing. Now, you're going to need to know some lab values. So the lab value for potassium is 3.5 to 5.0. Glucose normal levels is 70 to 110, and sodium is 135 to 145. Some other terms you may need some review on are ecchymosis, which is bruising, erythema, which is redness, and hemorrhage, which is massive bleeding, which we want to prevent at all odds, okay? So the best solution to clean blood is going to be chlorine bleach. I already talked about C. diff. Remember, you're going to use soap and water. It's the only thing, and it's really like the friction, so you want to use a lot of friction. What is a hospital-acquired infection? It's acquired infection from the healthcare system. Like the patient comes into the hospital, they get pneumonia. That's a healthcare-associated infection, and we want to prevent those at all costs because you're going to get dinged. from the Joint Commission because of it. But not only that, is it really fair to our patients to have them come into the hospital and we give them an infection? It's not. So, like, remember your protocols no matter how busy you are. Keep to the sterile technique, okay? So, the most common cause of HAIs are IV therapy. Priority action is hand washing, I talked about, I'm sorry. Sublingual means under the tongue. Transdermal means topical medication. And then enteral route means via the GI tract. Parental route means outside the GI tract, which is an injection. Intramuscular route means into the muscle, and rectal means inserted into the rectum. So the best route to administer medications in an emergency is IV because you bypass what's called first pass. I don't know if you learned about that in pharmacology, but just know when you give IV medications, they're absorbed immediately. Okay, so that's you've got to like double check everything, especially when you're giving like phenytonin or dangerous medications. You want to make sure you're giving the right medication because there's no takebacks. All right. Um, the IV administration absorption rate is quick because there's no barriers. Normal 24-hour intake, 3,000 mLs. And we had talked about in med surge class that your intake may be slightly more because you have insensible losses, like when you breathe, you lose 900 mLs per day, just breathing. All right, signs and symptoms of infiltration. Remember, it's going to be cool to the site, swelling, pallor. Okay, in pain. If your patient complains of pain, take the IV out. If your patient is complaining, it's cool, it doesn't feel right, take the IV out. The most important thing is to make sure, like your patient, do all your checks before you start an IV. Ask the patient if they're allergic to latex and adhesive tape. Okay, usually you would find that out beforehand. But if you're admitting them and just starting an IV, you may need to find that information out. So you're always going to check allergies before you give medications and do all the, I think we're up to 7 or 8 rights right now. Remember, your sterile field border is 1 inch, and 1 inch equals 2.5 centimeters, and that area in the border is not sterile. You should keep sight of the sterile field. The sterile field needs to be from waist to armpits, okay? And only sterile items can go in the sterile field. You never reach over the sterile field, right? Disinfectant kills pathogens on inanimate objects. Antiseptic can kill pathogens. Remember the chlorhexidine scrub we talked about in surgical? That could be considered an antiseptic. It goes on skin. If you get a needle stick, the priority action initially has to be to wash with soap and water, follow up with occupational, your healthcare system's occupational or employee health area, because they'll tell you what the steps are to do for a needle stick. I've had a couple in my life where I had to get immunoglobulin, and it's an IM injection in both butt cheeks. It's a 2-part injection. It was not fun, and had to get a lot of labs drawn as well. What life-threatening complication can occur in fluid overload? So if you're giving a lot of boluses, so a bolus would be like somebody's dehydrated and the provider orders a 500 ml bolus. That's something that goes in quickly, okay, because they need fluid now. But you are going to monitor for pulmonary edema because you don't want to overcorrect, especially older people. If you have an older adult that goes into pulmonary edema due to a blood administration or IV therapy, that's a reportable incident, okay? So you don't want to have to report to the Joint Commission that you put somebody into pulmonary edema. So watch them closely, listen to their sounds, lung sounds. A local infection, an example, is phlebitis. In sepsis, that's an example of a systemic infection. The chain of infection, remember the infectious agent, the reservoir, the portal of exit, all that fun stuff you learned in fundamentals. And then with pulmonary edema, some of the signs and symptoms include pink, frothy sputum, a new cough and crackles, shortness of breath, orthopnea, meaning the patient can't lay flat. Get them up in the bed, get them upright, put some oxygen on them. The provider will probably order some furosemide. So pay attention, check their potassium beforehand. All right. And that's IV therapy infection control.